Good morning to you all in the audience. My name is Paul Carson. My pronouns are he, him. I am a training and development specialist here in the pharmacy department at CareOregon, and it is our pleasure and our great privilege to be able to present to you today as part of our Meds Ed program, which is a series of ongoing clinical education presentations that we offer throughout the year. Today, our topic is fentanyl. What to know, what to do, and what's coming. You're going to also have the opportunity this morning to get registered for our upcoming sessions. We try to do these fairly frequently. You see that we have one coming up in April, continuing our focus on substance use disorder. This one is a realm of SUD we don't normally hear a lot of information on, but where it's really desperately needed is in the hospice and palliative care space. So you'll have an opportunity to enroll for that anytime you like. That registration is live. Just a couple of housekeeping things, and then we'll bring up our first presenters here today. Well, let's get started. Everybody who is with us here today will have the opportunity to get 2.5 hours of CME or CEU credit, depending on what you need. I'll cover all the red tape of that and the procedure at the very end of the session, but it's extremely simple. We want to make it really easy for you folks. So that's all been taken care of, and will be a painless process for you, which we all love. Here's a snapshot of our agenda this morning. After we do our introduction, we have the presentation broken up into 4 segments today. Timing is approximate because, sometimes people speak a little faster. Sometimes they, have more, a little bit more to dive into, and things run a little bit long, depending on how things go. But this should be the general structure of the day. We should have an opportunity at the end of the presentation for questions and answers. So throughout our presentation today, we're going to be working on the chat. The chat is for you to take advantage of with any questions that you may have for our presenters. We'll collate those as we go, and hopefully have a chance to answer as many of them as time allows for us here today. Sound good? Let's do it. Here is a look at our core learning objectives, the ones that will be that we use to file for our CME and CEU. We're going to talk about how new additives that we're seeing, like Xylazine, are impacting the direction that the fentanyl crisis is heading. You're going to gain an understanding of some of the best practices for OUD management in hospital and outpatient settings. And you're going to be able to talk about how to transition from fentanyl to buprenorphine and subblockade. So I think you're going to come away with this a lot of tangible assets today. My friends, we know why we're here, and there's no secret. We live in sobering times. Drug overdose deaths in Oregon more than doubled between 2019 and 2021, with the increase driven largely by misuse of the powerful synthetic opioid fentanyl. And it's a trend that has continued since then. Fentanyl has become a leading cause of overdose deaths, particularly among people who don't have access to harm reduction services. This trend is prompting urgent requests for supplies of naloxone, the rescue drug that rapidly reverses an opioid overdose. Nearly a third or more of Oregon's counties saw more people die from fentanyl overdose than overdose from any other drug. So friends, our goals today are simple: to provide you with tools to help you feel less overwhelmed by the situation, to create empathy for the people we care for, and to hopefully save some lives as a result. To kick things off today, I'd like to introduce somebody who manifests doing all of these things in the course of her typical daily work. I'd like to introduce you, to start things off, Stacie Andoniadis, Substance Use Disorder Integration Program Manager here at CareOregon. She's going to say a few words, and then we'll introduce our first presenter. Stacie, please take it away.
Hi, good morning, everybody, and thank you, Paul. I just wanted to share a few words of gratitude and thank everybody for being here today. This is a chunk out of your daily time with patients and clients, so we just are so grateful for your time. And we just really want to thank you for providing daily excellent care to our patients and our clients during a very challenging and ever-changing time. It's consistently difficult, and we appreciate your daily focus and work with this very at-risk population. We're committed to hearing from you and supporting you while you do this work every day. And so we just wanted to send or share a note of gratitude and say thank you for being here. And we're just very grateful that you are taking the time every day and including being here today with us. So thank you so much. And I will hand it back over to Paul.
Thanks, Stacie. You are a bit of an unsung hero, I think, within CareOregon. I don't think you get as much attention or recognition for the work that you do as you should, but we've been incredibly lucky to get to partner with you on so many occasions here in MedSed, and I just can't say enough about the work that you and your team are able to do. You make a tremendous difference for people. So all our gratitude goes to you, my friend. Okay, I think we should go ahead and get rolling. Let's introduce our first presenter here today, and it's my incredible pleasure to introduce Dr. Amanda Risser, an addiction physician and family doctor who works at Central City Concern here in Portland, where she is Senior Medical Director of Substance Use Disorder Services. Central City Concern provides a continuum of care provided to folks with substance use disorders, including withdrawal management services, outpatient behavioral and medication treatment, supported housing, and residential services for women who are parenting infants and young children. In short, they do a lot, and it matters in a tremendous way. So it's my tremendous pleasure to welcome Dr. Risser. Please, Amanda, take it away.
Good morning, everybody. Thanks so much for being here today. I'm going to kick things off with an overview. My colleagues a little bit later on in the presentation will get into a little bit of the nitty-gritty day-to-day how you manage this medication for your patients. I'm just going to start with slides I often start with. Pretty much anytime I talk, I want to give us a foundation for how we talk about substance use and folks who use substances. And the reason why this is so important is that one of the most important things that we can do as addiction professionals and people who take care of drug users in our practice is mitigate stigma. There's research that shows that mitigating stigma and approaching people with these use disorders with unconditional positive regard makes them more well. And part of that is how we use language. There's a lot that is baked into our language where when we talk about substance use and people who use substances, there might be ways that we talk about them that may be unconscious to us, conveys stigma, conveys a negative connotation. And there's been a linguist who's been interested in this for a long time, Dr. Ashford, and he has periodically published about which words seem to be more problematic than others. I think number one is abuse. Abuse consistently is shown to convey a negative reaction to the listener. Another thing that we try to avoid is language that's not person first. So, you know, I don't describe my patients as addicts or alcoholics. I describe them as people with substance use disorders, and usually I'm specific about that, especially if I'm talking clinically. We try to avoid words like clean and dirty. And some of them, there's a little bit more nuanced and evolves quite quickly. So sometimes it's hard to keep up to date, but there's some evidence that the word relapse is more negative than other words like, you know, use recurrence or return to use. Some of these are a little bit finer points. I think what I'd like you to hear is to hear loud and clear the word abuse, because that's been the most strongly linked to negative negative connotations. And then I'd also really love for us to think a lot about clean and dirty and how we use that clinically, and encourage us to actually never use that word clinically. And you might be thinking, wait a minute, I hear people use this language all the time, you know, and my really good friend who, you know, is got in long-term recovery, and, you know, we have great conversations about how he's an addict or an alcoholic, and do I tell him to stop? No. This is all about recovery dialects. When I'm here giving a presentation to a community of clinicians, when I'm writing, when I'm talking to my patients, I'm going to utilize clinically accurate language and language that mitigates stigma. If, you know, a friend of mine who is a clinician and in recovery goes to a meeting, they're going to use whatever words feel appropriate to them to describe their own experience. So this infographic on this slide just speaks to that a little bit, and I just would really encourage you to think about it and think about ways that you might use language clinically that you could shift. I would argue that using words clean and dirty to describe somebody's use patterns or their urine drug testing is not accurate enough or helpful enough in clinical practice to really be useful. So I would encourage you to think about things like, oh, my patient's here today, they're doing well, their urine drug screen shows X, Y, or Z, and then you can move on. All right, language. We're going to move on to fentanyl in Oregon. We have been expecting fentanyl to come. It's been in the East Coast, it's been in Canada, and I just was knowing it was coming, was paying attention to how is it affecting other communities across the nation and to the north. And I started having a little bit of magical thinking. Maybe it would never arrive. Maybe it would be okay. Maybe we'd be spared it. Maybe things would change, because the drug supply is always so dynamic. Well, it arrived. It arrived really firmly at a pretty terrible time in about 2019, right as we were entering the COVID era, which was a just incredibly difficult time for all of us, especially folks with substance use disorders or other health conditions. And since 2019, overdose deaths in Oregon have increased by 600%. So those are opioid overdose deaths, and called them fentanyl overdose deaths because that's what they are. All opioid deaths right now are linked to fentanyl for the most part. So in 2021, 509 individuals in our state died of an opioid overdose, and that's compared to 71 in 2019. Here's a graph showing that. The top blue line is methamphetamine overdose deaths. I feel like often those deaths are invisible to us because they are not, a coherent syndrome of like, this person took methamphetamines and then turned blue and Narcan didn't revive them and they died. That's not how methamphetamine deaths present. They're usually more complicated. They're usually, cardiovascular deaths or accident deaths, or, they're different than you would expect. They're a little harder to capture, but I just want us always to remember that methamphetamines also cause a huge amount of morbidity and mortality in our community, and also rose over this time. And then the gray line is fentanyl deaths. And if you see the orange line, which is heroin, kind of went down over time as fentanyl goes up. Really, fentanyl has universally penetrated our drug supply. All right, well, what is fentanyl? It's a synthetic opioid. It's not really much like the fentanyl you might be used to using in the hospital. It is a mixture of a few different analogs, carfentanil, all kinds of, it's sort of messy. It's a methy substance. It has unusual effects at this receptor level compared to other opioids. It conveys a really high tolerance quite quickly to the euphoric and analgesic effects, but it doesn't really decrease the respiratory depression ceiling. So folks will be driven to use more and more to feel well, while there being really no difference in at what point they would overdose. It's super dangerous for incidental users. We're used to substances when they're smoked to not be fatal because, people usually substances are such that you would fall asleep and stop smoking before you died. But with fentanyl, we're finding that incidental users, when introduced to this substance, will overdose even with smoking 1 puff or 2 puffs. It's highly lipophilic. It distributes into tissues very quickly. It has short-acting properties where the euphoric and analgesic effects and the effects on somebody's withdrawal symptoms are relatively short-acting, while the fentanyl that diffuses into the body systems kind of leaches out slowly. We're likely going to have some more information about that later in the presentation. And we're finding that the dopamine activity in the nervous system is higher than what we're seeing with heroin, and it's a little more like methamphetamines would be, with some of this kind of very dramatic dopamine release in the brain and nervous system, and that makes it a little bit more difficult for folks to stop using because they just feel so bad, so dopamine depleted when they stop. All right, how do people use it? Well, hopefully you've seen these blue tablet pictures around. Those are really important to recognize and talk about, especially with teens and young people who may still think that these oxycodone lookalike pills are oxycodone. They're not. They're fentanyl. They're always fentanyl. Then they're generally smoked in a pipe, or which is either made of foil or glass. Foil is very, very common. That's a foil pipe that's unwrapped, kind of shows you what it looks like once somebody has smoked it. And then increasingly, we're finding that our patients are using fentanyl powder, which can be both smoked and injected. And that is just kind of a natural progression as individuals' tolerances grow and increase. Folks are not, we're taking care of patients who are smoking 40, 50 fentanyl tablets a day, and inevitably they're going to move towards powder, which tends to be more potent, and it's just less to handle, less volume, less money, less time consuming, et cetera, because they can use more and it has a longer effect. All right. What else are we seeing? Well, we're seeing concurrent use of fentanyl and methamphetamines, and that is probably part of the story of the mortality data that I showed you, with the lines going up, 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 with methamphetamines on top of fentanyl. We're finding that our patients are often feeling that they need to use methamphetamines along with their fentanyl in order to counteract the sedating effects of fentanyl so that they can function and stay safe. We're finding really amazing penetrance of Narcan, intranasal Narcan, into the community. And when we take histories of our patients, we're finding that often in the months and years prior to presentation for treatment, that they have been treated with Narcan multiple times and administered Narcan to multiple people. And this is really significant because there's some estimates that if somebody has survived a non-fatal overdose, they have probably a 5 to 10% chance of dying in the next year. Drug users are really distressed about this change. This is not a welcome change to the drug supply. This is something that folks are feeling fearful about, upset about, grieving, the fact that their use disorder, in order to be, for them to maintain themselves, to feel well, to function, that they are having to turn to a very potent and scary substance. And then it's a lot more difficult to transition somebody to a medication that would be helpful, and folks are really grieving that as well. I think both users and folks who care for users. So we're also seeing increasing numbers of folks injecting fentanyl, and we expect that to increase. We've had a period of time of relatively lower rates of injection drug use. Most people have been smoking the fentanyl. Some folks are still injecting heroin, or what they believe to be heroin, although more and more folks who are, the small number of folks that are using heroin are finding that it's adulterated with fentanyl as well. and then some folks are still injecting methamphetamines, but people have been largely smoking fentanyl, and we expect that to stop. We expect people to be injecting in the next 1 to 2 years. That's what happened on the East Coast. That's what's happening up in Vancouver. And so we'll see a return of a lot of the morbidity that we see with injection drug use more broadly. We also are seeing that fentanyl has adulterated many other drugs. And so this is the main contributor to some of our really tragic losses with teens and young adults. Prior to the fentanyl era, it became pretty common for teens' first drugs to experiment with would be in pill form: Adderall, alprazolam, oxycodone, usually diverted from folks' medicine cabinets. But now that folks' medicine cabinets are empty because some of the the changes in prescribing patterns and the way that opioids and benzodiazepines are prescribed in the community, people would still seek those pills because that's what they were used to, what their peers were using, and now pretty much all of them are adulterated with fentanyl. So I attended a memorial service in the summertime, somebody who overdosed at school, a 16-year-old. The folks that are drug checking in our community are finding that things that look just like alprazolam tablets, things that look like Adderall, are adulterated with fentanyl. What do we expect to see also in the future? We're expecting xylazine or trank dope skin conditions to start manifesting themselves. What's probably happening is xylazine is in our drug supply, and we may not be seeing some of the morbidity from it yet because people aren't injecting as much. And we're expecting to see, and I'll talk about xylazine in a sec. We're also expecting to see more benzodiazepines in fentanyl. That's what's been happening up in Vancouver, and a lot of communities have been dealing with that for a while, where fentanyl is adulterated with some of these laboratory created benzodiazepines like etidolazam or flubuprofen. These are novel benzodiazepines that are made in labs in China and imported, and they're starting to be mixed into fentanyl, which makes it really complicated because opioids and benzodiazepines mix pretty poorly in terms of safety. And again, we're expecting folks to start injecting. So what is xylazine? It is a new adulterant, and it's probably here. We've seen a few sporadic cases of intoxication syndromes or overdose events or some skin issues that may be related to xylazine. It hasn't really been here, like really arrived, but we're starting to suspect it's here in a few sporadic cases. It's an animal tranquilizer. It's been an adulterant in opioids, and it's been in the East Coast for a while. And it's really interesting, it causes localized vasoconstriction in the skin. And this can occur remote from injection sites. We're really used to dealing with soft tissue infection at the site of injection, and these are sometimes, not near the site of injection. The intoxication syndrome is dangerous. People are seeing sedation in their patients, bradycardia, hypotension, altered mental status, unconsciousness. So somebody may be appearing to have an overdose, treated with Narcan, aren't coming around like you'd expect because other things are on board. And the wounds are really of concern. The intoxication and withdrawal syndrome. The withdrawal syndrome can really be tumultuous, and in severe cases might require ICU stays. And then we're seeing also on the East Coast and in Canada some wounds that are really difficult to heal and at risk for infection. And there have even been a few cases of folks requiring amputation. So we'll probably see more of this, and we'll be watching for it. All right, Sublocade. Sublocade is a novel treatment. It's a monthly injection of long-acting buprenorphine that requires about 5 to 7 days of sublingual buprenorphine prior to injection. It is especially helpful for people who are transitioning who have trouble transitioning onto and then staying on sublingual buprenorphine. In our setting, we're really reserving it for folks that, we just cannot get them to get onto and then stay on buprenorphine. It's just really difficult for them to manage that. Maybe it's because their medication is frequently lost or stolen, maybe because there's in an environment where there's frequent contact with fentanyl. Sometimes it's just they're really having a hard time avoiding use because of that really, reinforcing dopaminergic effect and experiences that folks have from withdrawal. And there have even been a few cases where somebody, has to turn themselves in to Clatsop County Jail, and they're not sure how long they're going to be there for, and they're scared they're not going to get their buprenorphine, and they don't want to lose, lose the ground they've gained in their sobriety. It's actually really common. A lot of times when folks enter recovery and kind of are starting to really gain solid ground there, it's when things kind of catch up to them. And I can't tell you how many folks I've counseled through that moment. And Sublocade can sometimes be useful in that situation as well. All right, something that we've learned as we've been providing folks with Sublocade in our system is that sometimes people require sublingual supplementation initially. Research shows us that folks that have not been stabilized on buprenorphine prior to Sublocade injections are more likely to require this. So, if somebody, you're just like getting them started onto Sublocade straight from their first, week or so of sublingual buprenorphine, these are going to be folks that are more likely to have that. And what we're finding is that our patients are really telling us what they need and how to supplement. We're being relatively permissive. We're giving them counseling about how to up titrate to comfort and avoid oversedation or slowness, stickiness side effects that you might have from too much bute. And usually folks are requiring it for like a week or maybe as long as 12 weeks. We see them pretty frequently, or talk to them on the phone, and talk them through how to manage that. And it's pretty rare for us to see somebody needing it longer than 12 weeks. And it's usually in the 4 to 6 week range for the folks that require the sublingual supplementation. Sometimes folks are being maintained on 300 milligrams of Sublocade because usually you get 2 injections of 300 and then you go down to 100. Rarely people really need something different than that, but sometimes they do, especially the folks that are just really having a hard time without a bunch of sublingual bute. All right. Another thing that we're seeing that's really emerging is a demand for methadone. And this is something that we have learned about from other communities affected by fentanyl, where methadone demand increased by 30 to 40% as fentanyl penetrated the drug supply. And the reason for this is it's a little easier to start on methadone. You use fentanyl, you show up at a methadone clinic, you get started on methadone, and the idea being is that you up titrate methadone, you down titrate fentanyl. Nobody expects people to be able to stop right away. I think the challenge is that sometimes it's hard to up titrate the methadone fast enough to get people comfortable. It's really common for folks to feel underdosed, and our methadone partners at opiate treatment programs are really working hard to be, within the constraints of the federal guidelines to increase folks' methadone as quickly as is safe to get people safe. I think we just always need to remember that methadone is a fantastic medication. Our community has been really lucky in that a lot of folks have been well served by buprenorphine as well, but we're really finding that we need to really pay attention to methadone and talk to our patients about methadone as an option if they're just really finding that buprenorphine is not helpful. And then, of course, if they want to start on methadone, learning how to support them into an opiate treatment program and support them as they're getting that treatment is really important. All right, what else are we seeing? We're seeing that folks need higher doses than 24 milligrams. When we learned our foundational teaching about how to prescribe buprenorphine, we were told 24 milligrams is the ceiling. That's like after that, your body is saturated. But we've had some low barrier provider partners in regions kind of similar to ours or more remote where there's no methadone available, and they've just got to work hard to meet people's needs without that as an option. And they've learned that about 20 to 30% of their buprenorphine patients are requiring doses of greater than 24 milligrams to treat their cravings. And we're finding about the same in our practice. I'll show you a slide and a couple slides up how they came to that determination. So why did we get this idea that 24 milligrams was the ceiling? Well, that was based on a MRI study on those 5 people who got MRIs of their brains. Do you remember that slide from for those of you that got your data waiver? This is a foundational slide in data waiver training. It was from 5 heroin-dependent volunteers in 2003, and it studied the mu receptor occupancy relative to placebo, and found that 16 milligrams a day occupied 80 to 92% of the receptors, where 32 is 89 to 98%. And for a lot of people, having like maximal receptor occupancy wasn't necessary, right? And I think we certainly saw that in our folks that were using heroin. But for fentanyl, it really does seem to make a clinical difference. So this is a kind of a cohort study that the folks in Olympia and Ilwaco published, where they took 240 patients and 3,000 prescriptions, and studied like what were people stabilizing on. And they had a clinical approach where they were just really listening to their patients. They up titrated to effect. They were looking for comfort. They were looking for use recurrences, and they were just talking to their patients just like we would do for any other medication, and really listening to their patients when they weren't held by 24 milligrams and getting curious about that. And they found that about 20-25% of their patients were in that greater than 24 milligram range. And they published this. They're about to publish this. They're actually about to write a book, but they've been presenting at ASAM and other practice communities around. So I would really consider this as something that has been well vetted, well supported by experts, and not like out there at all, but pretty mainstream. So what we're learning from this is that buprenorphine has a near maximal effect at 32 milligrams a day, and that high receptor occupancy really met the goals of improved therapeutic effect. So I would listen to your patients. If they need more than 24 milligrams, work on that. Most of our health plans have adapted and approve doses greater than 24 milligrams a day. And just expect that you're probably, if you've got a cohort of folks, about 20 to 30% of them are going to need that if they're using a lot of fentanyl. All right, what about dosing greater than 32 milligrams? It really does seem like that is kind of a true ceiling. However, I've had a couple of people who I've prescribed greater than 32 milligrams, and those people are pregnant. Those folks are in early recovery, kind of experiencing this tumultuousness from high-dose fentanyl use. I wouldn't really expect that to last longer than 3 to 6 months. They can usually kind of drop down to 32 milligrams. Sometimes it could be helpful to manage acute pain exacerbations by providing a little bit more buprenorphine. That's one strategy. It's not always the strategy to use, but it's an option. And then sometimes we're really finding that our patients, if we give them kind of a handful of buprenorphine to support their transition from fentanyl to buprenorphine at home, and we see them with follow-up that they've taken 40 milligrams for a couple days. It's hard to say if that really made a difference, but the patients are telling us it did. All right, I wanted to just introduce a couple of hot topics. So drug checking. That's a harm reduction technique where folks can bring their drugs to a place that has a mass spectrometer, and where, in an unsafe drug supply, folks can really understand what they're about to use. We have one, this is an NPR story. I embedded a link in this slide that you can listen to from Boston. Boston is just doing a lot of really cutting edge, amazing stuff to meet the needs of folks that are using drugs, that they're well funded, well studied, and we're really following a lot of trends out of Boston. And we have a mass spectrometer at Outside In, and I talk to Haven from time to time and say, hey, what are you seeing? And I learn a lot, and our patients are learning a lot, and then they're empowered to use safer. I think most people who are using blue pills or fentanyl now know they're using fentanyl, and that's not a surprise, but this would be helpful for somebody who might be trying to use other things and don't want to be exposed to fentanyl. All right, another hot topic. So you may have thought about or heard about or wondered about whether or not, sort of the almost near ubiquitous smoking of fentanyl, if you walk into a bathroom that somebody has smoked fentanyl in, can you be harmed? And then you've probably heard some news reports of folks who, fainted or passed out or maybe overdosed from touching fentanyl or having topical exposure somehow. So most of these stories about folks dying or becoming unconscious from touching or being exposed to fentanyl have ended up being attributable to something else. And, the kind of initial report has usually been a little bit of like news media hype. I think that you can really reassure yourself and your staff that exposure to secondhand smoke from fentanyl and touching fentanyl does not put you at risk for overdose. We prepared this one pager for our staff. We'd be happy to share it. We've got a lot of staff that do, cleanup jobs, that are in outreach, that enter bathrooms. People are smoking fentanyl in some of our public spaces, and it's just really important to reassure folks that this is not probably something that is going to be clinically significant to them. So I'd be happy to share that one pager. We're really proud of it. I think it's kind of supportive because it also really empowers folks to, if you're in a situation that makes you uncomfortable, leave or get PPE or get some support, because, I think it's upsetting to be in settings where folks are using drugs. It's uncomfortable. All right, and one last note on overdose. So overdose recognition and response. I am an addiction professional. I know what overdose looks like. I carry Narcan with me everywhere I go. I give Narcan to my husband for him, and I've taught him how to use it. I've taught my children how to use it. There's Narcan in all of our cars. There's Narcan at our home. So I'm like really, and I also know that if I administer Narcan to somebody who is not overdosing, it really does very little harm. So if you're out in the community or somewhere where you think maybe you find somebody who's unconscious and you are remembering this presentation, or kind of what's going on in our community, you're like, oh my gosh, maybe this person overdosed. You still use your ABCs. You still use airway, breathing, circulation. You use your skills if you're BLS trained. You invoke 911. And having Narcan with you is great, and you can, after you've assessed the airway, breathing, and circulation, and make sure you don't need to be administering CPR or whatever, administering Narcan is definitely an option. There's a million YouTube videos, one by the CDC, which is particularly good. The Harm Reduction Coalition has lots of training resources. Those are the ones we use in our community and in our organization to teach people. A lot of times, giving somebody a sternal rub and saying, hey, I'm worried you overdosed. Can I have Narcan? Sometimes people will wake up and talk to you. And I think just knowing that administration of Narcan will not harm folks if they are unconscious. Sometimes it makes them irritable and uncomfortable if they have truly overdosed, but you might have saved somebody's life there. All right, I am done.
Thank you, Amanda.
Yeah.
I think we have some time, Paul? I don't know if you wanted to go to some of the questions.
Yeah, we have a couple, Amanda. If you got a couple seconds before we transition, I'd love to field a couple of these your way if you could. Sorry, I had a couple technical things that were jumping across the board here. So
should I stop sharing?
You can leave that slide up if you
great.
like. It's fine, and we'll put another one up, and I'll share momentarily from my slides. So that's good.
Okay,
but you were talking about 32 milligrams, and Stacie, you might be in a good position to weigh in on this one too. But this person said that one of the barriers to prescribing 32 milligrams is that insurance often won't cover the cost of that dose, and they were wondering at some point if that barrier would be removed. Do either of you have perspective on that? Stacie, what do you think? Or is it something we should be checking with, like?
Yeah, I can speak to this, and I'm sure that Amanda also has perspective on this. I was actually just responding to that comment in the chat. At CareOregon, we don't have a prior authorization on 32 milligrams. That was a change made in February of 2023. I know that that's not the same for other payers. So I think you can work with your team and advocate for a change in the prior authorization to be able to prescribe the 32 milligrams or above. So that was a real community effort, at least in our regions. But it is, I think, it is a barrier, and it's probably payer specific. Amanda, do you want to add?
Yeah, absolutely. And I just want to, it was an advocacy effort and a partnering with Stacie and her team around, really considering what to do about this 24 milligram ceiling that was built into the payer reimbursement, and we were really really grateful that we were able to achieve that change. There was a workaround prior to the change that we utilized, with full transparency, where we prescribed different formulations, because sometimes the payer will have kind of built into how they do authorizations a system where you're allowed to prescribe no more than 3 tablets or 3 doses of each formulation. So it was really common for us in the months leading up to the change in the prior authorization, just because honestly it was so common for us to be prescribing doses greater than 24 milligrams. It was just hard to stop and slow down and submit a prior authorization for the folks that needed it right in that moment. So I was doing a lot of you're going to get 3 Subutex tablets and 1 Suboxone tablet, or you're going to get 3 Suboxone films and 1 Suboxone tablet, and just piecing them together that way. I think a little later in the presentation, we'll talk a little bit about mono versus combination product and how, thoughtful ways of approaching that. I would really encourage folks to feel comfortable prescribing mono or combination product. We've really not seen folks have a differential misuse rate for those, and there's some really good evidence to back that up. The folks in Ilwaco and Olympia who have been doing this work around advocating for doses at up to 32 milligrams have to submit a very well defended prior auth for each patient that they require greater than 24 milligrams. And they have this pre-printed prior authorization that gives 5 references with abstracts. And so they just have this packet they launch at their health plan every time that they need to give somebody doses greater than 24 milligrams. I'd be happy to share that. They have the same 5 references that are really pretty high quality research that supports their clinical practice. So I think that would be a strategy as well, just to be oh, here's 5 reasons why this should be supported, so that's something that I thought was kind of clever.
Awesome. And is there a timeline that you see folks titrating up from induction to 32 milligrams? This person said they have a few folks that they think need that amount due to fentanyl use and previously failed induction treatment. Am I conveying that okay?
Sometimes we'll talk through a home induction, and sometimes we'll talk through a home induction, and I'll see them, a day or 2 or 3 later, and they're up at 32 and they're feeling pretty good, and we just have them let that ride until that changes. Sometimes people will very much naturally decrease. And then Jennifer is going to talk more about this induction process and how quickly to up titrate. I think my short answer would be quickly. You can up titrate quickly. Don't mess around. Just let them stabilize. Let them get comfortable and gain some ground.
Right. We had a small avalanche of questions come in. So I'm going to try to get as many as we can before the top of the hour here. But are there any data on overdose from fentanyl-laced methamphetamine? And what are your thoughts on prescribing naloxone for patients who use methamphetamine for risk of fentanyl in the supply?
We had a period of time at Hooper where we were using this point of care test at the time of admission, and we were testing everybody, and we weren't seeing a lot of folks that were reporting only methamphetamine use, testing positive for fentanyl. I think we're worried about it, and we counsel people about it. And we didn't see a whole lot of it, at least until we stopped doing point of care fentanyl testing in our setting. So I don't stress. I don't treat people who are withdrawing from methamphetamines for fentanyl withdrawal because I'm just not seeing it. I think it's never wrong to give somebody Narcan. Chances are that if you've got a patient who's using methamphetamine, they're probably around fentanyl as well, and you can talk to them about how to use Narcan, and they might be helpful to somebody.
Fantastic. And then, gosh, there's a whole slew of them here. This person's sort of anecdotally saying they were at a Max yesterday, Max train for folks who weren't from the area, and they saw a guy who was clearly smoking fentanyl nearby, and they could smell it. They could smell it, and they're wondering if it would have shown up in their system. I mean, that kind of, I think, addresses back to like your job aid that you had.
Yeah, we don't think that, by the time that somebody's exhaling fentanyl from their body, it's very lipophilic, it really quickly absorbs into the system. I think it's very unlikely that somebody, like say you were drug tested, I think it's really unlikely that you would test positive. We have not seen that.
And then here's one. What do you think is causing infant fentanyl overdoses? Is it, this person is wondering, is it either secondhand or from mucous membrane contact?
I don't know a whole lot about infant fentanyl overdoses. I would really, if I'd had that happen in my clinical practice, I would want to really have long conversations with the medical examiner about what happened to any infant that I cared for that died of a fentanyl overdose. I think it's probably complicated, and I would be really, I think that would be the kind of thing that you'd really need to piece together with the data that comes out of the medical examiner report, the clinical history, et cetera. I can't really speak to that. I haven't personally, luckily, had that happen in my clinical practice. I know that some of my colleagues have, and I just haven't talked to them about what happened in those cases. So it might be something we'll have to report back to y'all about.
Okay, perfect. And then I don't know about this one here, but they said, has there been talk about distributors of Narcan possibly not being able to distribute any longer?
I think Stacie would help with that. No, not that I know of. I think just what I'm seeing is more and more Narcan being distributed in the community, luckily. And, I'm Kaiser insured, and I got my doctor to give my whole family, a prescription for Narcan with multiple refills, and I can even buy it at the pharmacy without a prescription. So I'm seeing increasing availability, and I haven't heard of any limitations there. Stacie, have you heard anything?
It doesn't seem like there's a shortage right now, right? People are able to get it when they request it. Excellent. Okay. Stacie, did you have anything you wanted to add to that?
Just get naloxone and hand it out as much as you can. Have your own personal supply and encourage your clients and patients to get some as well. I know, actually, we'll see, we do have some of our harm reduction specialists on the call, so maybe if they have any other comments, they can add them to the chat.
I did see, Stacie, your proposal to rent an airplane and drop Narcan from the plane. I mean, we might still try to do that if we can, but I know you're very ambitious with this. But and then another question here: are we getting anywhere with wooden chest syndrome that Narcan isn't helping in overdose situations?
I think we're all worried about wooden chest syndrome, and I think that I think of some of the folks who I've cared for who have gotten very sick or even died. That might have been an aspect of it. I think that we know that Narcan works. We know that Narcan, even that even with fentanyl, Narcan works. That airway breathing, circulation interventions work. I think that wooden chest syndrome is something that is seen, but I don't see it as, I haven't heard feedback that it is like widespread. I
Okay.
think it's a more sporadic and rare complication of fentanyl use.
And I got a couple more. I think we still have time to deal with these, so let's go ahead and try to see if you're still game. Let's try to see what we can do. People are fascinated and interested. A lot of engagement here today. What is the half-life of blue pills? At least general thought, understanding they can be mixed and are heterogeneous. Also, does route alter the duration of action? I'm not sure that.
Yeah, I mean, I think Emily's going to really help us understand that a little bit, and same with Jennifer. So I think of it as sort of like almost biphasic, and this is my broad overview, and then hopefully we'll get a little more detailed later. But I think that there's a lot of medications like this, even buprenorphine, where you are probably going to have. I see folks smoking fentanyl sometimes every hour while they're awake. So I think there's aspects of the fentanyl, kind of the blue pills and the fentanyl powder that is very short acting. And then I also see folks having tumultuous withdrawal syndromes for days to weeks. So I think that it has a short acting property. It diffuses quickly into the tissues with its, highly lipophilic nature, and then it kind of diffuses out slowly at a smaller dose.
Okay. And are there point of care fentanyl testing that I can get for my patients?
No, so there is no FDA approved, CLIA waived, low complexity fentanyl test that you can apply at point of care for your patients. It is not available.
Okay. And then I don't know if this is I think this might be coming up, but can you speak to tapering off of your initial data waiver suggested 3 to 6 months? And then they say, which pretty much never happens with my patients.
Yeah, no. So I hope if I taught you your data waiver class that we did not use 3 to 6 months as a tapering timeline. In fact, there's research that shows pretty much any time you taper somebody off of buprenorphine that they are at high risk for use recurrence. I employ a method where I tell patients that this medication I will prescribe to them as long as it is helpful to them, and that we're going to have an open-ended approach. If they have a reason or a timeline themselves that they want to taper down or off of it, I will support that, but with lots of risk-benefit conversations and an open door to restarting. I find that, I had the privilege of being in the same practice for 15 years prior to this job. I prescribed many people buprenorphine for the entire duration of my continuity relationship with them. It was normal for many of them to kind of have this natural down titration. I sort of imagine as their brains and nervous system heal and readapt that less medication was required. I also had patients who stayed on like a half a 2 milligram tablet every 3 days indefinitely. So I don't think having, I think encouraging your patients to have a very open-ended timeline and having your practice have a very open-ended timeline and being prepared to prescribe the medication to the patient as long as they want it, which may be indefinitely. And then also being prepared to slowly down titrate somebody who's motivated to get down and off and be open to restarts or increasing the dose back again. I'm seeing one question that I think would be really important to address, and I think I can just kind of quickly speak to it, and then I think Jennifer will have some perspective and Emily will as well. I've been told that the DEA is tracking how much Subutex we're prescribing at our clinic versus Suboxone. Are you aware that this is true? I don't think that's true. At least the last time I was visited by some DEA agents as part of their normal sort of tours of just checking practices, they were not interested in how much mono product and combination product I was prescribing. I'm not sure how that's going to change now that the data waiver is gone. They were interested in other things, but not that. I do know that some of our medication supply companies have internal ratios that they try to stick to, and that can be a barrier if you're an FQHC, for example, and you have an internal pharmacy. That happened at our pharmacy, and we pushed back and advocated, and they removed those thresholds for us, and we haven't had any issues since. So I don't think, you know, I can't, the DEA is a bit of a black box, but I think that they have learned over the decades that the mono product versus combination product is not really, there's really not a difference in diversion and misuse. It's not a very effective misuse deterrent, and I don't think they're really paying much attention to that. It could be wrong, but I have never, you know, I've been prescribing buprenorphine since 2003, and I probably prescribe mono product to 50% of my patients at this time, 40% of my patients, and I'm not run into any feedback.
Paul, you're on mute.
Oh, sorry about that. I'm good old
No worries.
reflexes there. This person shared that in Marin County, California, yesterday, apparently they began distributing Narcan vending machines
Oh yeah.
throughout the area. So that may be something that we start to see more widespread.
We've kind of already done this, and there's a community. God, what community is that in? I think it's in Pendleton or LeGrand. They have boxes that community peers replenish like every few days. They kind of drive around. It's part of their rounds as being community professional peers, and they just restock the boxes. And then we're working on an initiative in our housing program where we have boxes that we replenish too. It's kind of like a vending machine. It's sort of the same idea. Might be something that you could consider for your clinical practices. There are these boxes you can buy that, you know, from like Amazon that you can put on the side of the wall that look kind of like, you know, axes that you get out if there's a fire.
I think I'm myself interested in seeing like every school has a supply available. Every single one.
I think that Portland Public Schools is making sure that Narcan is available in each school at this time.
And then I think we got time for just two more quick questions here. How many intranasal naloxone doses are usually needed to reverse the effects of a fentanyl overdose? Just wondering how many doses should be kept in a primary care setting emergency kit?
Yeah, so we talk a lot about that. In our emergency kits, we have 2 doses, and there's just fentanyl everywhere. So if that didn't work, we have more around available. And then we actually have IM fentanyl as well that we utilize. So usually we'll do fentanyl, and then intranasal, and then move to IM if EMS isn't there yet. So I think it really varies. I unfortunately have been hearing from some of our jail colleagues who are finding that multiple doses are required to help some of their individuals who are overdosing in jail. We're finding, like in the Hooper lobby, for example, we probably respond to an overdose once a month or twice a month, and 2 doses of our Narcan are usually just fine. And sometimes it's hard for me to tell if somebody has required 2 doses or if I just waited long enough for the first dose to work.
That mute button's getting you today, Paul.
It really is. I just try to be, you know, courteous and not be the heavy breather here. So sorry about that, friends. A couple of people asked this question. Is fentanyl being mixed in vaped marijuana at all?
I don't know. I mean, I think it's not something I've seen.
Okay. And then last question. How do you decide to prescribe Suboxone versus Subutex in your patients?
Really good question. Jenny, are you going to be talking more about this? Kind of, yeah. We wrote a paper, and we can include that. It was like a commentary, and it was a follow-up to another one of our colleagues, Dr. Blazes, who wrote another commentary about this. So here's what I do. If I see somebody and they're like, oh, I'm feeling pretty good, but this medicine, man, it makes me so sick. I just have terrible nausea, or I've had a chronic headache ever since I started this medication, and I don't think it's really working out for me. I'd like to stop. Then I, you know, knowing that sometimes the naloxone component, although we were taught it does not really absorb under the tongue, we do find, when you do urine drug testing for buprenorphine, naloxone's always in somebody's urine when they are doing urine drug testing for, you look at it, you don't want a whole lot of naloxone to be in the urine, but a small amount is often in their urine. Then, okay, good, thank you. Then I often will switch formulations at that point and then see them on follow-up, and it's very common that the side effect that they were experiencing is gone. I don't know if you have a different experience, Jenny, but I think it's very as simple as that. It's like, oh, you're having side effects. It's what you ask about at any time that you see somebody on follow-up, like, how's the medication working? Are you constipated? Are you sleepy? Are you having trouble sleeping? And then, yeah, Stacie's going to drop the article, I think, share it with you. And then if the side effects go away, awesome. Just keep going. I think initially when I started being brave about changing formulations, I was a little worried. I'm like, are all these people lying to me, because they want to get the mono product? There's a lot of confusion about mono product versus combination product. There's a lot of preferences either way. And I just got really curious, and I talked to my patients a lot. It's like, hey, have you ever bought this off the street? Have you ever misused it? Have you ever heard of somebody misusing it? What was that like? What did that feel like when you injected your buprenorphine? Did you do it once? Did you do it 5 times? Did you do it every day? And just really, how much does Subutex cost when you buy it illicitly? How much does Suboxone cost? And what I've learned over the years is there's really never been a indication that folks are preferring to buy Subutex over Suboxone, that it costs more. I have people who sporadically inject, but rarely very often, and usually for some sort of reason that made sense at the time, and then they're like, well, that wasn't a very awesome experience. And then the vast majority of people who are using diverted medication is to treat withdrawal symptoms, with a goal of either doing that temporarily or actually even maintaining themselves on buprenorphine for a period of time. And it's not just something I've anecdotally seen, it's something that has been studied, and that has been, when research has actually been applied to it, that's what's been found as well.
Fantastic. Thank you for being so generous to answer all these questions here. And we do have more time at the end of the segments here today, friends, for more Q&A. So hopefully we'll be able to handle some more of that.